All right, it's 5 after. We'll go ahead and get started. I have a real busy clinic when we're done here, so we're going to get started and we're going to end on time. I think the topic listed is 3D echo. We're going to adapt that a little bit and talk about applications of 3D echo, largely for interventional echo. So for the sonographers in the room that aren't actually acquiring images during a TE, know that you probably could actually. So I was in Dallas last week and I was sort of hanging out with those guys and in their echo lab and their interventional lab and seeing what they do. And it was interesting actually. They had a sonographer in with every case, doing the image optimization, doing the acquisitions during their TAVRs, during their mitral clips, during their structural interventions. So we tend not to do that here, but the way we do it is not the way everybody does it. And particularly for those who are in training, I think it's worth for the fellows and for the sonographers sort of going through maybe some of the image optimization that we do in our cases. So we'll talk about interventional echo really as a tool to talk about 3D specifically. A bunch of learning objectives. It's always good to try to tell you what I'm going to try to tell you. So emerging role of 3D echo for structural heart guidance. Maybe talk about added value compared to 2D. And introduce a little bit of patient-specific printing, although for this particular talk we're not going to focus on that too much. So interventional echo really started with this kind of a slide. This is an off-fast 3D TE of mitral stenosis. On the left you see basically commissural fusion. The Doppler showed a 10 millimeter mean diastolic gradient. That's severe MS. The balloon goes up. This is a lateral view, indicating that you can get other off-axis views with TE, with 3D echo. You're not sort of stuck, and that's both the benefit and the curse of 3D echo, is that you have the ability to present off-axis views. If you do it randomly, you confuse everybody, but if you do it from time to time with an explanation, it actually can be very helpful. And this is after procedure where the commissures have been split, the valve area is clearly much larger, and the gradient falls by 50%, which is the goal. So now we're in an era, of course, we do structural heart interventions where we leave a lot of stuff behind. ASD closures, PDA, VSD devices, not necessarily used in those intended applications, although with Dr. Lin we're doing more and more of these adult intended structural heart procedures, but really we use these devices in sort of off-label ways, and I'll show you some of those. Particularly for paravalvular repair for those devices, LA occluder, the Watchman, the TAVR, mitral clip, and on the horizon is transcatheter mitral valve replacement, which will be incredibly image intensive. So, and just sort of a warning, and I'll show you some of that data at the end. So, typical surgeon's view. So in TE, and I must say our lab is getting better at this when we do diagnostic TE with 3D, but it's not yet universal. We don't present this view all the time. The idea is that you present the aortic valve at 12 o'clock looking down on the mitral valve. So when you do that, the aortic valve is not shown, but it exists right about here, somewhere between 12 and 1. In this case, this is the septum, posterior, lateral, and anterior. And so that's the standard. They call it the surgeon's view. More truthfully, it's probably the anesthetist view. But for interventional echo, this is the view, at least of the mitral valve. In this particular case, the big pink arrow shows you a lateral defect, paravalvular defect. In this case, patient was suffering from severe regurgitation and heart failure. Increasingly, as you know, we're going into the cath lab. Our echo images are being displayed onto bigger and bigger monitors, and the interventionalists are becoming more and more dependent on echo images. So fluoro time is dropping, ultrasound time is increasing. There's lots of issues around that in terms of manpower and radiation safety and all kinds of issues, but know that the echo is not in addition to the fluoroscopy, and for many of these procedures, the echo is actually replacing the fluoroscopy. This is an example in sort of one slide of a procedure, paravalvular defect, a transeptal puncture. Again, we don't use this little rotation feature very often. In this particular case, it was kind of interesting to show the length of the catheter, which is looping within a very large left atrial appendage and then diving across a transeptal defect. Sorry, not transeptal, across a paravalvular defect. Come down here, we see one device deployed, a catheter, and then finally 2 devices deployed, shown here. This is sort of the end result. So in diastole and systole, 3 devices deployed. And that effectively would not be possible without using off-fast 3D views to do that. This is a different case, same kind of problem, but it shows some of the detail and a little bit of the nuance with image optimization. So this is a case not so long ago. This was from the summer, August, end of August. Mechanical valve in the mitral position. You see over here a little washing jet. So the far right side shows a normal, small. One of the ways you know is that it's at the hinge point, and it's very short in dimension. If it were out lateral, the way this one was, or comes as far back in the atria as the way this one does, it would suggest a paravalvular defect. So this is a very medial paravalvular defect. It's scooting up along the atrial septum, so you know it's medial. If you look over here on an off-fast view, again, the aortic valve is up near 12 in play. With normal gain, which is the sort of the basic, you basically on a 3D image, you turn down the gain until the blood mud or the brown stuff that exists in the blood pool all disappears. So this is sort of normal gain, blood pool just cleared of the brown stuff. And there's a suggestion of a little dimple over here, but it's not really evident that it's not definitive that there's something there. You suspect it from the 2D images that there's a septal defect, but you don't yet see it. But if you actually turn the gain down a little lower, you start to make some structures look a little moth-eaten. But it does really clarify. There is a shadow here, and the arrow's probably a little overlapping, more than it should be. But there's a problem right here. So that sort of tells you that you've got a defect at 1 o'clock. Now, the way you confirm that is you put the color on. So with on-fast view, you think there's a defect. With the color on, there's clearly a defect right there, and that's paravalvular. This is the so ring. These little bumps are the single interrupted sutures the surgeon used. So this is a very low frame rate, 2 hertz. Okay, the volume rate is 2 hertz. You would think that's useless. But for this particular application, that's all you need. You just need to get one systolic frame to see exactly where the defect is. So we criticize 3D echo for super low frame rates on color. Depending on the question you're asking, it may be useless. But in this case, a volume rate of 2 hertz is really all you need. So there's a big color defect, confirms the suspicion. We're confident where the defect is. And sometimes we do this. You sort of take that data set and you can rotate it around, in part to make sure that's the only defect. So again, you see these tiny little bits of color. Typically, washing jets are at the hinge point. So there's a hinge point here and a hinge point here. This one's a little tricky because the paravalvular defect is actually right beside the hinge point. But know that these little washing jets aren't random. They don't occur just anywhere. They tend to occur near the hinge point. So if you're seeing something you think is a washing jet and it's not near a hinge point, it's probably not a washing jet. And that's where the off-fast views can be very helpful to trying to figure that out. So several views confirming the location, suggesting severity. We can do a 3D vena contracta. It's one measure of severity. Again, you've only got really one good systolic frame here. You could get more. You could ask if you're working with an anesthesiologist for a breath hold. You could stitch together up to, this is probably just a single beat. You could stitch together 4 or 6 beats. You might get the volume rate as high as 8 to 10. It's never going to be 30. But you can increase it if you need to. But we've got one decent one. You can do an area, a vena contracta area. The dimensions here were 3 by 10. More so the dimensions here were try to roughly size the device that would go in here. So 3 by 10 was the device. We weren't necessarily looking for for a vena contracta area in this case because the patient was symptomatic. This is the defect. We're going to fix this no matter what the vena contracta area is. But for device sizing, the color can be very helpful. So go through this. So this is a paravalvular, a transeptal puncture. Guide wires across, pointing then straight down. So the guide catheter is positioned over the defect. There's the defect. We have one device now positioned. So we've now deployed a paravalvular. This is actually an ASD designed occluder, but it fits very nicely in this paravalvular space. But this is actually occluded, and this color is actually the result after this is in. So we have still a catheter. There's a wire there. A device has been deployed. There's always concern that if the device overlaps too much with a prosthetic valve, you can actually interfere with cusp leaflet closure. Particularly in this case, we're very close to the hinge point. So these are some of the things you have to evaluate very quickly using live echo. There's no other modality to do that. But if we look closely, we had this deployment. We still had a little too much color. We sort of said, well, we're probably going to have to put in a second plug, which we sometimes do. But we just said, let's look closely. Let's look really closely. Let's zoom in, even within 3D, And when you zoom in, you can see that, in fact, the edge of the device is sort of lifted up. So there was a guide wire still across the defect. The catheter is here. See if I can pull out, does this thing have a, there it is, right there. It's just lifted up on the edge. So in fact, the guide wire was still across the defect, and the guide wire itself was lifting up the edge of the device. So communicated that to Dr. Barker, who said, hey, I think the wire is actually interfering with the device lying down flat. That's what it looks like on a live 3D echo. He just wiggled the wire a little bit. The wire slipped around the side. The device fell down flat. So you can see it over here in the next view, I think. Oh, sorry, I don't know where my arrow went. Here it is. So it lay down totally flat, and the regurgitation was basically gone. So it didn't necessarily need a second device. It just needed a close inspection of the first device. And that's the sort of troubleshooting that, if you understand the 3D echo, if you know that you can zoom, you can put in a very small sector. It doesn't have to be big. I mean, you're sacrificing frame rate if you want to go big. You get a smaller frame rate if you go low. But in that case, that's all you need. So you've seen these slides before, transcatheter heart valve. We do a lot of this stuff. 3D echo can be very useful during the procedure if there's complications, particularly for paravalvular leak. But you all know we don't routinely do 3D TE at all now during our TAVRs. During our learning curve, we certainly depended on, but increasingly we go with fluoro and with our operator experience. But when there's trouble, they still put the probe in. Anesthesia does their best, and when they're stuck, they call us. But this is an example of a failed expansion. This is a self-expanding valve. This is using X-plane, so technically 3D, or it requires a 3D TE probe. And you can see this valve is kind of squished. It's released. It's supposed to be self-expanding. It should have assumed a circular configuration. It did not. We called this the pancake valve. And when you looked on the lateral, simultaneous lateral, it just wasn't big enough. Was this hemodynamically important? There's the still shot, and yes, you measure with catheters, and there's still a very significant gradient across. So this particular patient needed a balloon expansion of what was supposed to be a self-expanding valve to overcome some regional calcification. And this is the fluoro showing the frame was sort of dented and non-expanded. When you superimpose the CT data set and where a big lump of asymmetric calcium was, you understand now why this frame didn't expand, because it had to deal with this. That was overcome largely with a balloon. The valve still wasn't particularly pretty. It was still asymmetric, but the gradient was gone after balloon deployment. Other obvious complications, you don't need 3D for this, but part of the goal, or part of the benefit of having the probe in, when stuff goes badly, you find out about it quickly. Aortic rupture and tamponade and a quick intervention to save that one. Ugly things in the aorta, you can see with 2D. They're certainly well appreciated with 3D. This enormous wiggler, and this post-procedural dissection. This dissection was from an attempt to retrieve a valve. TAVR had been deployed, didn't like the way it was sitting, put a guide wire across, try to pull it up. But of course you're pulling from the groin, which means you're putting a lot of tension on the lesser curvature of the aortic arch as you try to pull the device up. So basically you're sort of sawing across a lesser curvature of a 90-year-old arch, and sometimes bad things happen like that. But that's not necessarily 3D. So this is a case that did require some 3D. And I'm going to show you a few cases now, really just to sort of emphasize some of these principles. So young man, end-stage renal disease, on hemodialysis for multiple years, multiple previous graft revisions. He actually had a percutaneous transhepatic catheter, which I'm not sure I've ever come across. He'd had a pericardial a mitral valve several years earlier. I think there was concern at the time about non-compliance and anticoagulation, so in retrospect, maybe not a wise move to put a bioprosthetic valve in a young man on dialysis, but it was done elsewhere. Comes to see us, chronic severe mitral stenosis, elevated diastolic gradients, of course, respiratory failure. Intubated refractory pulmonary edema, RV failure, surgeons say inoperable. This is what does echo look like? X-plane, including mitral stenosis, prosthetic mitral valve stenosis with all kinds of spontaneous contrast in the left atrium. On the off-VAS view, this valve doesn't even look like it's moving. I mean, you look at this and you think, how is this gentleman alive? Where's the flow across this bioprosthetic mitral valve? In fact, when you put the color on, there is some flow. And one of the features you can do with live TE is actually do a direct planimetry of the color to give you a sense of the effective valve area. So it's tricky to do. I'm only going to show you one frame, but it was estimated about 1.1 centimeters in a guy who was in extremis with a mean diastolic gradient of 18 millimeters mercury. This was our first attempt, first case we did, of a transapical valve-in-valve mitral repair. So this is done in the hybrid OR. This is beating heart, no bypass, large catheter through the apex of the heart. It's Dr. Reardon, Dr. Barker is assisting. There's a guide wire. This is, again, viewed from the left atrium. So guide wire is coming up through the left ventricle across this prosthetic valve. This is actually a sapien valve designed to go in the aortic position, which is being deployed across the bioprosthetic mitral valve, and it's just about to be inflated with a balloon. That's the fluoro image, sort of showing all that hardware, the sapien within the bioprosthetic valve and a transapical catheter. And this is what it looks like when you put a sapien valve inside a bioprosthetic mitral valve. The valve area immediately more than doubles, and mean gradient follows very appropriately to what would be normal for a mitral valve, basically 3. So, you're not done. You have to look and make sure that everything is going as well as you think it is. You can do X-plane. You see all the leaflet motion is normal. And in this particular case, really no mitral regurgitation at all. No transvalvular, no paravalvular. So an example of, some of what you do with 3DT during these procedures. And there's the before and after. He did very well clinically. The other activity we're very involved in is MitraClip. If you're not familiar, MitraClip is basically a transeptal delivery of a clip, which grabs typically the anterior and posterior elements of the mitral valve, pinches them together, creates a double orifice valve in diastole, and improves the coaptation in systole. The expectation of MitraClip is significant reduction of MR. It's typically not elimination of MR, but for many people, they just need a significant reduction. It's challenging in terms of the quantitating the regurgitation you're left with after a MitraClip. So this is several examples. This is a patient who received 1 clip, and there's a significant residual MR. This is an example of a patient who received 3 clips and has this sort of eccentric, perhaps significant, difficult to quantify regurgitant MR or resultant MR. This is somebody who received 2 clips and has these crisscrossing MR when it's all said and done. And this is somebody who received 2 clips and actually ended up with 5 independent regurgitant jets after MitraClip.
The reason it's difficult just because eccentric jets, because of the clipping, or multiple different jets?
All of the above. So multiple jets, eccentricity, they're going often in different planes. You've got device now there, which is going to create imaging artifacts, so it sort of limits the ability to appreciate the flow in multiple views. You typically have sick people to begin with, so you're looking at other non-echo parameters like flow reversal in pulmonary veins and left atrial pressure, but they're so abnormal to begin with for this patient group that it's hard to track a difference and know that you've done something important. And this is just one sort of extreme example where, you've got 5 independent vena contracted diameters, and you can try to add them up. But, so us and other centers are trying to evaluate is there a 3-dimensional approach to this that might be a little more robust than the current guesstimates. And that's sort of what we end up with. This I've shown this before, but this is kind of the mitral whack-a-mole. You clip it once and the MR appears somewhere else. You clip it there and then it appears over here, so you're constantly chasing the MR jet with various clips until you run out of diastolic gradient. This is a different case. 91-year-old gentleman. He had a remote history of CABG. Now presents with frank dyspnea at rest. The echo is pretty obvious. He has the worst combination. He has an aortic valve that doesn't open, and he has a mitral valve that doesn't close. So this is AS with functional MR. So you see the posterior leaflet is tethered. You see this little hooking here of the anteromitral leaflet. You see systolic tenting, and you see the complete lack of a coaptation in the center of the valve. So just the sort of thing, it's easy to appreciate probably on a 2D echo. In 3D, it's a little more impressive. And then the clinical question is, how do you treat this? Is it TAVR? Is it MitraClip? Is it both at once? Is it MitraClip then TAVR, TAVR then MitraClip? So those are the challenging clinical problems. This is a case, this is really an interesting case, but it's more the introduction to the case that follows it. So I think you've probably seen this case, and I'll go through it quickly. 67-year-old, lots of reasons that she's very high operative risk. cirrhosis, end-stage renal disease, pulmonary hypertension, and she's got decompensated heart failure in hospital for a month on inotropes for the last several weeks. Prohibitive surgical risk. This is her echo. A nice normal aortic valve, which doesn't matter in this case, but she's got a thickened posterior leaflet with a perforation through a portion of the posterior leaflet with central coaptation that looks okay. So, leaflet perforation on 3D. It's kind of here. It kind of looks like a little crater in the posterior leaflet. It's sort of in the transition between P2 and P3, probably P3, but the tissue is so abnormal there, it's actually hard to be confident which scallop it's in. We had a lot of clipping experience, questioned whether, in fact, plugging experience with paravalvular defects, questioned whether we could put a plug right through the native leaflet. So this was the concept. A dog heart was available to us in one of the labs in the RI. Not sure how it got there or why it was there, but it was available. So in this case, I'm glad it was available. So we took something like a hole punch. We recreated as best we could the defect for this patient in the mid-posterior leaflet. And we tried a bunch of different devices to see really which device had the best profile, both above the valve and below the valve, that would actually occlude the hole, but not interfere with all the three-dimensional structures around it. So this is a vascular plug 4. It's got a very high profile. Clearly, it's probably too high a profile to expect it to function properly in the left atrium. It would interfere with tissues. This is a vascular plug 2. Occluded the hole, but had such a long bulk that it would interfere likely with subvalvular apparatus, with chordae and leaflet closure. Then we sort of, kind of like Goldilocks, we tried to find the device that was just right. Amplatzer duct occluder 2 was a device that seemed to have a fairly flat profile below the valve, didn't interfere with leaflet closure or chordae, at least in the dog heart on a table. And you look from above, it also had a fairly low profile. So the thinking was this device would do the job with minimal potential for obstruction of the other functions of the valve. So we went with patient consent to do this procedure. This is the aortic valve over here, so this is not the standard presentation, but RA is over here, transseptal catheter, sort of shown in this view just to see how it dives into the mid portion of the posterior leaflet. This is before, this is the MR, perforation, this is hole, catheter, device down the middle, final result, device placed, and over here we see a significant reduction, and actually no regurgitation through the defect, but now a little bit of regurgitation through the central coaptation zone. And that was the final result. This one's rotating really to show you how much motion this device now has. Thankfully, it's relatively close to the annulus, so it's the annular positioning or relative positioning of the device that limits its motion a little bit, but it's very mobile. This was a year ago. Patient's been followed, has done very well. Device is still there. Patient still suffers from her comorbidities, but she's not had a hospitalization for heart failure. So from a technical success of the procedure, she's done very well. But a year ago, we said, if this sort of case ever happened again, we wouldn't rely on a dog heart. We would probably do 3D printing of a heart and practice it that way. And I'll show you that in a second. So at our center, we've done a bunch of 3D printing, typically of aortic valves, of aortic root constructs, a little bit of some of the left ventricle, but in recent months, we've started to look at 3D printing the mitral valve. This is a patient of ours. This is from the CAT scan data set about 4 years ago, just before she had her TAVR. But she also has very significant mitral valve dysfunction. So this is a hard plastic model. This is looking down on the left atrium. This is the sort of very obvious appendage over here, and this is the same appendage from a different view. This is a 3D print of her aorta that we did several years ago, and this is a picture of the model of her aorta in our flow lab. But this is just sort of one of our first attempts to look at 3D printing her mitral valve. Other people have done some preliminary work on 3D printing. Maria, who's a postdoc working with us, along with help from Eleonora and some of the anatomic tagging. This is now taking a 3D TEE data set. So you take the data set in 3D TEE, it's a DICOM file, you export that DICOM file, and then you do this manual segmentation where you actually identify the elements that are mitral valve. So that takes some time, and it's iterative, but it sort of looks like this. You take a 3D TEE view, and eventually you create from that on a computer system the isolated mitral valve components, and this is sort of a spinning version of a diastolic frame of the mitral valve from TE, sort of taken up to the annulus. So a lot of the annulus surface could use a little smoothing, but in terms of the relationship between the aortic, the anterior and posterior leaflet, and their configuration, it actually looks very good. So why does any of that matter? Because this is the case, the next case that presented almost a year later after the first case. A little more complicated. Another gentleman in his late 50s, prohibitive surgical risk, had a clear history of endocarditis, now healed. It was a couple of months ago, afebrile, sterile blood cultures, but has again a perforation of the mid-posterior leaflet with some mobile elements and calcification below the defect, complicated also by a central MR. And on his 3D, you see a similar crater as the last patient in combination with a central coaptation defect. And because of pulmonary hypertension and end-stage renal disease and a bunch of factors went with it, deemed prohibitive surgical risk as well. So as we said a year ago, if this sort of ever happened again, we would 3D print a heart instead of trying to rely on a model dog heart. So this is a 3D print. This is based on a CT, not yet a TE. And this is looking down at his mitral valve. We made the leaflets clear and opaque so you could see all the yellow stuff. And the yellow stuff is the calcium that exists below the valve. So the yellow is actually deep and the clear is the top. And this very sort of asymmetric defect here is the hole that was evident, and that was his primary problem in terms of regurgitation. So we then met with our device reps and said, what are all the devices we have access to? What are the possible things that could fit across this defect? Ultimately sized it to this particular device, which is an Amplatz Ductor 2, and we looked at its length and its size of the cup and all the features that would be required to close that hole. We then took the device into the model, and this is looking from above, closing the hole, but importantly looking at the device from below. We print the model by chopping off the apex so we can see up into the subvalvular apparatus where all that calcification and patient-specific stuff is. Asking the question is, will this device lay down flat or even close to flat with all of that calcification and abnormal tissue there? And it did, provided we didn't go too big with the device. So that was all sort of related to device selection. Then, like the first case, the procedure, shown here in just one or two slides. Transeptal puncture, a wire across the defect. We actually did a MitraClip first. The thinking being MitraClip first would help with the central defect, but it would also stabilize the posterior leaflet to facilitate the second procedure. And this is basically a MitraClip and plug through the posterior leaflet, and a very significant reduction of his MR severity. So I started this for a little few minutes, and I kind of thought it looked like a blinking dog or something. And it was killing me. I said, where do I know this image from? And then I remember this, the never-ending story dog. Anyway, I see the resemblance. Not everybody does. But so that patient did well. He went home in 2 days, and he's due to come back and see us soon. So that's the never-ending story case. So in terms of 3DT and procedures, there's an evolution. So, the surgeon gets the advantage of soft tissue, direct line of sight. Echo gives you soft tissue anatomy, function, and flow information. And fluoro brings in devices, which, even with echo, some of the devices, some of the guide wires, are if they're covered with a hydrophilic coating, they're almost invisible to echo. So X-ray still has importance to sort of gives you a very large field of view. It shows you some relationship with catheters and devices and wires, which are sometimes very tough to see by echo still. So the idea is bringing all these together into one environment is important, and there's lots of different vendors working on this, and Dr. Barker and I are doing some animal work and trying to work with one particular vendor to see how robust this technology really is. But the idea being you combine both the echo data set and the fluoro data set on the one screen, and so instead of having to look back and forth and do this mental interpolation of what this image is in relation to this image, you actually put them together in what's called fusion imaging. Both are relatively live, but they're not both exactly live. So you can have live fluoro with live beating echo. It tends to be you acquire an echo, you tag various features, and then you superimpose it onto the fluoro, and the fluoro can be live, and the echo is several seconds old, or the echo is live, and the fluoro is not. So they're not yet both live images, but that may be coming. And there's all kinds of different applications for this. And the question is being asked are how much added value is this? And the technology is too early to answer that yet, but it has the potential and it sort of makes sense, and we'll figure out within probably a year or two how useful this really is. The sort of in terms of why interventional echo is a field that is not going to go away. This is sort of a one-slide summary. So if you look at TAVR, it really began in its infancy in 2002, and then we're here with multiple devices, multiple vendors, multiple different iterations, and an ever-expanding patient pool. The risk profile is getting lower and lower for patients who are getting TAVR. The mitral space really was just the MitraClip, but cardio-Q, neocordi. This slide doesn't even include the transcatheter mitral valve replacement, so I'll show you in a second. And then, of course, left atrial stuff. So, the structural heart intervention field is growing enormously. So transcatheter mitral valve replacement. This is TAVR, an inch to the right, or an inch to the left. Much harder in terms of the technology. Anchoring these devices is much more difficult. So a TAVR device almost universally is anchored by just radial force in a calcified root. Anchoring has never really been a problem with TAVR. It's an enormous problem because in TAVR, when the pressure is highest, the valve is open. High pressure systole valve is open, so it manages. These mitral devices have to be competent and closed during the highest pressure state. So blood pressure is 140. These valves have to be closed and not be forced back into the left atrium. So the anchoring issues are much more difficult on transcatheter mitral replacement. And there's a bunch of different devices, and they all have strengths, weaknesses. They're all at various stages of buying and suing each other. And we'll see within the next couple of years which ones come to fruition and which one we're involved in as a clinical trial site. But again, similar to the valve anti-valve case I showed you, these are going to be echo-dependent implantations largely. And this is one particular published case series or case. This is again looking from the left atrium, my aortic valves at top, transcatheter device coming up from the apex. Image to the right, it's sort of allowed to open up. It opens a bit, and then it has to be rotated and oriented based on 3D. So the native anatomy has to be known and stable, and then the device is rotated in position relative to the native anatomy. So there's a lot of concern about patient selection, device selection, and all of it's going to be imaging dependent for this technology. One of the concerns is that every one of these devices creates what's called a neo-LVOT. So unlike a surgical valve replacement, these devices, there's no removal of the anterior leaflet. So now you're putting a device there. If you haven't taken out the anterior leaflet, so where does it go? And do you force it into the LVOT and get SAM? Or worse than SAM, it's not even systolic, it's just permanent. So it's a big issue in terms of dealing with the anterior leaflet and avoiding SAM, and that comes down to the aortic mitral angle, the septal thickness, the length of the device, the length of the native leaflet. That's the predicted Achilles heel of all of this procedure really is anchoring and disruption of the left ventricular outflow tract. And there's a lot of work being done in that field now. So we went fairly quickly through kind of a lot. I wanted to show you some cases, particularly where echo and TE can be helpful, and emphasizing that the frame rate issues with color are a limitation, but that doesn't mean the data is useless. In the right application, it can be very helpful. So on the gradation of echo, and really interventional echo is really synonymous with 3D. Sometimes it's just X-plane imaging, but the ability to rapidly look at something off angle in 3 dimensions is really what interventional echo requires. So at the low end of sort of the added value spectrum, you have things like ASD repair. So when you're doing the learning curve, really learning curve for any structural intervention, the 3D helps, but once you know how to do it, and you can rely on a very little bit of fluoro, you may not need echo all the time. LA occluder I would put in there as well. We're doing more and more Watchmans. There is some echo requirement, but it's pretty simple. TAVR is debatable, and I'm actually in the midst of an online ACC debate, and the title is Routine Use of TE for All TAVR. Some say yes, I would say no, but select use of TE and 3D TE for TAVR absolutely. Depends on the patient risk and any evident complications. Intracardiac mass biopsy, this is something we have some experience with E-Step and crew. When they want to put a bioptome into a right heart mass, showing them that bioptome in 2 dimensions is very helpful, and we've done maybe a dozen cases like that. But at the high end of the added value is really MitraClip or mitral interventions. MitraClip, valve and valve, as I've shown you, but paravalvular repair and transcatheter mitral valve replacement, absolutely. So steep learning curve, lots of communication, but it is an example of sort of teamwork in the new environment. So I'll stop there and take some questions. Fellow sonographers, staff, John. Anybody? Crickets? Mahash, you made eye contact? Yeah, that's a bit of a loaded question. In centers across the country are solving that in different ways. So I know some centers where cardiac anesthesia does it, where they do all the MitraClips, all the TAVRs. That's not typical. Some places have a 2-tier. It starts with anesthesia with the call for help button to get cardiology. Some places it's sonographer driven. As I said, I was in Dallas last week, and they have not only a sonographer present in the room, but they have a sonographer who actually requires the vast majority of the images. Their sonographers are manipulating the probe in the OR, I guess under the direction of the anesthesiologist technically, but the sonographer is there first. The probe is put in by the anesthesiologist. The sonographer is capturing the vast majority of the screening TE. So all the basic shots to begin with that take 10 minutes at the beginning of a case. And then the cardiologist comes in, quickly reviews those images, and is there for the action part of the case. And I'm not sure what the details are in the regulations, but some centers do it like that. So there's lots of different solutions depending on the workflow. But at the end of the day, the images are good, they're reproducible, and there's a comfort level. Yep. Yep. Hey. Well, it really depends on the size of the valve that you're going into. So, most prosthetic mitral valves are pretty large. They're not limited by a small annulus ever, really. So, if you're going into a 25 or a 27 valve, our case, the gradients have been very respectable. I'd say between 3 and 5, mean. They're good. And they're probably closer to the normal function of the prosthetic valve than you would get in a aortic valve and valve, because the aortic valve and valves tend to be smaller, tend to be much more dependent upon all of that flow area. Mitral valves largely are over-designed. I mean, you don't really need, a 3-centimeter mitral orifice. You can get away with it too, because nobody has significant stenosis until you're down to 1.5. So the gradients across the mitral valve after this procedure are good. The challenge with that procedure is that people are so sick, and it largely requires a transapical. And transapical, whether it causes morbidity or it's just a marker of sick patients, the risk, the 30-day death rate for transapical mitral valve and valve is still high. Yeah, but the gradients aren't. Yeah.
Can you comment on the TE procedural time for the involved?
Yeah. So I'd say our first MitraClip was case probably 4 hours total time. The unpredictable part is, getting one clip to the target area. It's getting faster and faster. A lot of that, I'd say now our standard MitraClip is probably an hour total. The variable is a transeptal puncture. That can be very hard because sometimes it's easy, but if you get an enormous left atrium in a small person, then all of the cardiac anatomy is oriented in a very bizarre way. And although by echo I can see it, I find myself trying to convince Dr. Barker to push the needle. Because on fluoro, he's seeing this needle going somewhere where there shouldn't be a heart. And you get this, this sort of confidence going like, look, it's there. It's on X-plane. I see it tenting exactly where it should be in 2 views. Trust me, you're not going to go, I don't know, Steve, look at this thing. It's going way back here. So sometimes the transeptal takes longer than you would want. We spent an hour just trying to do a transeptal. And then the other wild card there is how many devices you're going to put in. And functional is tougher because you end up, the whack-a-mole concept is more evident if you've got big billowy leaflets and more of them. Whether that's a Barlow's. I think now we've probably done, 45 MitraClip patients, and we've seen probably almost every, a representation of every version of the mitral spectrum, from Barlow's to P3 to P1 to functionals to post-ring. So we've actually done MitraClips now for mild MR, but with hemolysis, typically after a surgical ring. So I'd say our average time is probably 90 minutes now. It's come down from 4 hours, but that's taken, 40 cases to get there.
Yeah.
Yeah, so that's a very good question. That's an area that is, I think, we're trying to figure that out. So the instructions with the device always say start A2P2, and if that's the biggest jet, that's easy. You go A2P2. The problem you get into is when you try to outsmart the MR. You think, well, I see the biggest gap here, but I predict if I clip here, the next one's going to go here, so I'm just going to go here first, and then you never get it. I know there's a European experience where they've started with the big functional cases to start from the edges. They put lateral and lateral, and they sort of clip in to sort of, you corner the MR, so it has no choice to get it. Our approach still is go as central as you can. Hopefully that's where the biggest jet is. Part of the rationale is when the coaptation zone is very small, you need some stability. So it's almost like just get one clip on, bring things in a little tighter, and then the next clip you get bigger bites, and you can bring it in tighter again. So it's not necessarily that you're actually increasing the width of the tissue bridge, but you're tightening the belt a little more with the second clip because you can get a better piece after you got the first clip on. So sometimes we just go middle, get some apposition, knowing we're going to have some MR, and the next clip just goes in right beside it. Yeah, oftentimes, if it's still a central jet, because sometimes the first clip is almost non-functional. It's just to stabilize things and get you enough stability to get the big clip on. So it's really the first clip is a warm-up for the second clip. The second clip is the one you want to perform most of the MR reduction, and then you debate a third clip based on if it jumped to one side or jumped to the other side, and also whatever the diastolic gradient is. One of the real problems, and we'll talk about it in the, obviously in the review paper or in the guideline we're writing, is it does a very tricky thing sometimes. You put one clip on, and if you look from above, you see the next regurgitation comes lateral. So you're looking down from the top, there's a clip here, and a clear lateral jet. But when you flip it up or you look from the ventricle, the jet actually starts on the medial side and crosses over under the clip and appears on the atrial side to be lateral. Now what do? Do you clip it where you see it in the atria, or do you clip it where it originates in the ventricle? We've got a bunch of cases where it actually crosses like this. And you're like, shit, I don't know what to do. Yeah, yeah.
Is there any way where you can put information and model as if you were clipping different areas?
Mm-hmm. So that's a good question, Belinda. That's kind of what we're trying to get to. So we're just signing a contract with Abbott to do in vitro MitraClip modeling. And that's basically to see how much of this residual MR is predictable. If you had the same anatomy and you can 3D print the anatomy, you can roughly approximate, pretty closely approximate the hemodynamic conditions, at least the pressure gradient, and say, if I always put the clip here, will I always get the MR here? Or, and maybe the question is, if it's feasible and you could do in a few select cases, is do the entire procedure on a benchtop first and saying, okay, if I do this, this, and this, we should have no MR. We're not there yet. Yeah, no, the valve tension is a big deal. the amount of tethering, you know, the ventricular size and dysfunction is a big factor. How much of the leaflet you actually get. And one of the challenges with the MitraClip is you have to close both arms at the same time. And we've often advocated we need independent closure. You need to be able to grab one leaflet and then kind of pull the catheter over and grab the other leaflet. But that's one of the reasons the procedure can take so long, is because you have no choice. It's close both or close neither. And that was an FDA safety concern, is that if you started grabbing one leaflet and you reach for another one, you'll rip off this leaflet trying to get to the other one. So there's a pro and a con to do that, but it's a tech limitation at the moment. Is you're very limited in how much you can actually do with the closure. Yeah. So anybody who hasn't yet come into a case, you know, can't all come at once, but individually you're all welcome to come. We have 3 MitraClips on Monday. It's a great venue if you just want to, you know, play with a very long T. Practice some color and do some reconstructions. Come on down. All right, I'll stop there and get to clinic.